When we assess the current approaches or practices that we're using to manage moderate to moderately severe postoperative pain, the type of pain that would keep a person in a hospital, what we're finding is that we probably could be doing a better job. Right now, the majority of the patients in that type of setting with that type of intensity pain are exposed to an opioid. And there are a lot of concerns about this. There's a lot of concerns related to the on-target and off-target effects of that opioid, meaning that we want it to produce analgesia, but at the same time, there are side effects like ileus, pruritus, other things to that effect that we have to deal with. And they can result in delay in discharge from the hospital, increased costs. I think we've seen this over the years. There are certain types of new healthcare practices that are evolving, like the ERIS system, Advanced Recovery After Surgery. And these are programs that try to make the patient accelerate through the pathway in a very stable and potentially pain-mitigated fashion. They rely on multimodal, multi-mechanistic analgesic strategies, and they are administered in multidisciplinary teams. There is a big emphasis on trying to move to an opioid-free post-surgical type of opportunity. And we see some innovation out there in the market that may allow for this. We notice that in a hospital setting, it may not be as easy to administer a multi-mechanistic analgesic regimen. A lot of the agents that you have might be oral, and they may not be appropriate for a first-day post-operative patient. Most patients are only staying in the hospital for about 2.5 days at most, if that. So we need to leverage technologies and analgesics that are non-opioid based, and we need to employ those in the perioperative periods. That means maybe preemptively, intraoperatively, and then postoperatively in the floor. And the hope is that we'll be able to provide adequate analgesia and at the same time reduce opioid consumption.
One of the interesting fallouts of the opioid situation is that people are beginning to think about, well, what do we do? What do we have if we have far less opioids or no opioids? So we've been forced to reevaluate what's available and ask those questions. You know, where are they good? Where are their shortcomings? And we're realizing, I think, that there's been a bit of dark ages, as I call it. We haven't studied the nonsteroidal drugs in a long time, or certainly not with the same intensity and degree of effort as for neuropathic pain. Acetaminophen, the same thing. And then just some practical things like, well, how do you administer it? You know, what are the regimens, by what route, etc.
Some models are now saying we're going to start with a non-opioid analgesia as the backbone of the pain management and then rescue with an opioid. So changing paradigms in light of this opioid crisis is extremely important. The question too comes, what happens when the patient leaves the hospital? Well, what are your analgesic options? Are you going to not use opioids in the hospital but then send them home with a prescription of opioids? Where's the value of that? How does that play out? These are all things that I think we're going to better understand in the next few months. And our colleagues at the FDA are undergoing a revamping of the guidance documents in order to develop these type of options, whether they're pharmaceutical or medical devices, to help ensure that patients are going to get safe and effective analgesic postoperative care and be able to transition out of the hospital with minimal exposure so that we can avoid the downstream continuum that may be related to extended exposure of opioids postoperatively.
Everything that Joe just said about the clinical viewpoint has been mirrored in the basic science approach to treating pain. And there was, and continues to be, a lot of rapid advances in understanding chronic pain, neuropathic pain. And so I think it's just human nature that the basic researchers are drawn to that. It's very exciting. And a lot of advances were made. But just as Joe was saying, there was a tendency to think of them as different, that there was acute pain and there was chronic pain, and the mechanisms were totally different, the treatments would be totally different. And to some extent, that's true. But we're now more realizing that you start out with acute pain and go on to chronic pain. And yes, there's different physiology, maybe even different anatomy, but if you can break that transition, then you can attenuate some of that chronic pain. This past year has seen an explosion of interest and attempts to, relook at these things and try different things and look for what we still need. And there's been, I think, some very exciting new basic science that suggests some new and exciting drugs to come. So in a sort of maybe unexpected and odd sort of way, the opioid situation, which probably is going to run its course eventually, but it has certainly stimulated a lot of thought and rethinking about all the other possibilities and optimizing the treatment of all types of pain, not just those that are exciting to work on this particular time.